Good afternoon, everyone from Mascoma Bank. Welcome this afternoon to a webinar about vaccines that we hope you will find really helpful. I'm Karen Borgstrom. I'm the Director of External Affairs for Dartmouth-Hitchcock Health. And joining me today are two experts on vaccines, Dr. Aalok Khole and Tricia Zahn. And I'm going to have them introduce themselves to you so that it's more comprehensive than what I could put together in a short intro, because their backgrounds are super interesting, and I think you'll find them very helpful and full of information. We'll have an opportunity at the end of the webinar after their presentations for you to ask questions. If you do have questions as they present, you can type the questions you have into the chat, and we'll be monitoring those, and then they'll be able to get to those questions at the end. So let me turn it over to Dr. Khole, and he'll start the presentation, and then Trish will introduce herself after that. Thank you.
Thanks so much, Karen. Let me just pull up my presentation. All right, there we go. So my name is Dr. Khole. I'm the infectious disease physician here at Cheshire Medical Center in Keene, New Hampshire, as a part of the Dartmouth-Hitchcock health system. I was born and raised in India, moved to the United States in 2013, finished up residency, chief residency, and then fellowship all in Massachusetts, in Worcester, about an hour, 20 minutes away. And then fell in love with New England and hence decided to stay on. Moved to Cheshire and joined here in August 2019, and then was welcomed by a pandemic within 6 months of starting here. So I would say it was a grand welcome, and it's been a year to say the least. So Tricia and I are going to try and talk about the vaccines, which everyone's excited about, more and more phases opening up. So we'll try and give a background about what's happening in the world of vaccines, how it influences everyone, including the general public. And then Tricia will go over the process of getting the vaccine, especially here in New Hampshire. So just to state, no disclosures. Sources of information today, CDC, the Advisory Commission on Immunization Practices, documents that were submitted by all of these vaccine companies to the vaccine regulatory boards, New Hampshire State Health Society, the New England Journal of Medicine, Lancet, New York Times, and then learned colleagues from which we've learned so much this past year, and without whom this would not have been possible. So if folks have not gotten a chance to look at this, I would highly recommend looking at the New York Times. They have this amazing vaccine tracker that they've kept up with respect to information around vaccines, what's happening globally in the world of vaccines. And as of 31st of March, when this was last updated, globally, 6 vaccines have been authorized in early or limited use. 7 vaccines have been approved for full use, and you can see several others which are still in multiple different phases of testing. As of now, leading vaccines on the right of your screen, Pfizer, Moderna, the 2 vaccines that are here in the US, as also Johnson & Johnson. The Oxford AstraZeneca vaccine still not available in the US, but has been approved in several countries globally. And then you have the other vaccines which kind of have a regional distribution. So with respect to vaccines in the US, Pfizer and Moderna both were granted emergency use authorization back in December 2020. Seems like a long time ago, but technically just a little more than 3 months. Johnson & Johnson, which was the third of the vaccines to get an approval towards the end of February. AstraZeneca Oxford vaccine, we do have the phase 3 results of their trials in UK and other parts of the world. They did release a sort of a press release early on, which then had debates and conflicts surrounding it, but they landed up on a number of about 76% efficacy. We are yet to see that in hardcore data, and hoping that happens in another 2 or 3 weeks. Novavax vaccine, which again, we have access to their UK data, not to the US data, has not even been talked about yet, but the hope is the phase 3 results would likely be available either in May or June of 2021. That's the hope. That'll be potentially the fifth vaccine being added to our armament. So to talk about the Pfizer and Moderna vaccines, both are mRNA vaccines. The technology, when it came out, everyone was worried. Have we, bypassed safety regulations? Is this too quick? The answer is no. The technology isn't entirely new. This is something that has been experimented with for about 10 years. Different vaccines, including flu, herpes simplex, zoster. They've tried to play around with this technology to create vaccines for the same, but they didn't have as good a result, primarily because mRNA is quite a melty structure, if you may call it that, meaning it's not extremely stable with respect to temperature changes, which is what was resulting in issues. But this time around, when they came up with the technology for the Pfizer and Moderna vaccines, they had it coated in a lipid molecule, which is what led to strict cold chain requirements being part of the logistical issue in rolling these vaccines out early on. On the right of your screen, you'll see how the mRNA vaccines work. Essentially, when we first started, everyone was concerned whether this is going to integrate with the host cell DNA and create issues with respect to genetics and future generations. The technology, if I was to sort of explain it in a pictorial format, is quite simple. So once you inject it, the muscle cells take up the mRNA, so it's in the cytoplasm. It's the part of the cell which is outside the nucleus, so there's no interaction with your own DNA. The mRNA, being a messenger RNA, as the name suggests, trains your cell to produce the spike protein. So it does not produce the whole COVID virus. So you cannot get COVID from the vaccine, but what it does is it essentially trains your cells to create the spike protein, which is then presented on the surface of your cells, allowing your immune system to learn as to how it needs to create a response against this, such that if you were to get infected by the true virus, your body would have already seen it and is able to mount a response in quick enough time. These were the first mRNA vaccines to receive authorization for use. Once again, it's key to understand these, though they use the mRNA technology, they are not live vaccines, which means you don't have to be worried about using them in immunocompromised hosts, using them in pregnant women. Those are not major concerns with the use of this vaccine. The Pfizer vaccine was authorized for 2 doses to be given 21 days apart. The Moderna vaccine was studied as 2 doses given 28 days apart. The data is primarily based off this regimen. CDC allows a grace period of 4 days, especially if you were to give it within this time window, meaning if you were to give it less than 21 days apart, then you have a 4-day window, and so on and so forth, even for Moderna for the 28-day window. As regards the upper limit of till when can you give it, we have data to now say that up to 6 weeks out for the second dose is okay. We do have enough supply, and the way the scheduling has worked out, early on the concerns were that folks may not meet this time window, but we've been doing pretty well on that front, and I'll allow Tricia to speak more about that. Both these vaccine trials were sort of balanced for age, ethnicity, color, race, all around equal. Earliest data was published at about the 2 months interval. And an astounding 95% efficacy was noted in both these vaccines close to 14 days after the second dose, which is where individuals are being deemed immune. And interestingly, this efficacy was seen to last across age groups. So it's not like one particular age group should get one vaccine versus the other. That was not the case. From an indications perspective, from an authorization standpoint, Pfizer was authorized for use in adults greater than 16 years of age, and Moderna was greater than 18 years of age. Most recently, last week, Pfizer put out some preliminary data in a press release talking about impressive results that they saw in their initial trials in ages 12 to 15 years, as good as 100%. I do want to say that comes with a caveat that if you look at the original trials, they compared about 20,000 vaccinated individuals to 20,000 placebo individuals. These trials in the adolescents were about a total of 2,500, so that's about close to 1,200 people in each group. So if you were to increase those numbers, there's a good chance the efficacy might drop. but again, not surprising. And we don't suspect that it would drop significantly such that it would be a cause for concern. But definitely good news, especially if Pfizer uses this to go on and extend their emergency use authorization for use in these particular age groups as well. Looking at this promising data, they have launched ongoing, the next group of trials for younger age groups, 6 months to 11 years. Pfizer is not the only one doing that. Moderna has joined the groups as well. Again, when this was first rolled out, we did this in a phased approach. At this time in New Hampshire, as of late last week, all phases are open. In Vermont, we should probably be heading into all phases being open in the next 2 weeks. Coming to adenovirus vector vaccines, which is what is used for Johnson & Johnson. The AstraZeneca vaccine is also based on this platform, but I won't speak much to it because we really don't know where that vaccine is headed with respect to use in the US. Johnson & Johnson is not new to this technology. They've used this and had success with it with respect to their Ebola vaccine that was approved in the European Union a few years ago. Essentially uses an inactivated viral vector. So it uses an adenovirus vector platform. It's a replication incompetent virus, meaning that should not cause disease. What it's doing is it's acting as a vehicle for the spike protein DNA. And then the subsequent steps are pretty similar to what the mRNA vaccines do, is it's presented on the surface of your cells, allows your immune system to learn about it such that you're protected if and when you may be exposed to the virus. The advantages, especially with the Johnson & Johnson vaccine, they studied it as a one-dose vaccine. It's easy to mass produce, and because there's no real lipid molecule, the cold chain requirements are lesser, which makes it really easy on the logistics and operations. I will say, though, that Johnson & Johnson is currently actively working on a trial looking at 2 doses because there is a chance that immunity may dip at about the 5 to 6 months interval, and that is where the second dose that was being used in mRNA vaccines may come into play. So coming to the Johnson & Johnson vaccine, it was more of a real-world trial. The reason I say that is it was done at a time when variants were circulating. This was done in a multi-centric fashion. They conducted studies in the US, South Africa, UK, and South America. So all strains of concern were effectively covered. The data, they got a lot of flack because everyone compared numbers. They showed a 72% efficacy in the US, 66% overall. Folks were concerned how this played out with respect to the 95 that you saw in Pfizer and Moderna. But again, these trials were very different. They looked at different outcomes. They were done in different times. And hence the request was it was not a fair comparison. What's interesting though is, and obviously reassuring, is it did great when it came to protecting against severe disease, hospitalizations, and deaths. At the end of the day, that's what we're looking at the vaccines for, is to try and give the healthcare systems an ability to recover, yet keeping the disease morbidity in check. Johnson & Johnson vaccine was concerning, especially with respect to dip in its protection against the South African variant or B.1.351. Several other vaccines have also had these concerns, but again, a few log changes in your neutralization antibody titers shouldn't really affect the actuality with respect to protection against disease, and that's what is the bigger picture we need to be looking at. As I said, single dose, lesser cold chain requirements, and longer shelf life up to 6 months. This definitely became a game changer. However, supply issues have remained constrained with respect to J&J, and hopefully that picks up. Again, this was authorized for use in individuals greater than 18 years of age. Contraindications, if you look at it, there aren't too many. The only absolute contraindications include severe allergic reaction like anaphylaxis to a particular vaccine or any component of the vaccine, or an immediate allergic reaction to the vaccine or any component of the vaccine. An immediate allergic reaction is something which would happen within half an hour to 1 hour after you received the vaccine, and someone was not able to delineate what exactly did you react to. Predominant component in these mRNA vaccines related to the lipid molecule includes polyethylene glycol. There was talks about potential cross-reactivity with another component called polysorbate, which is a part of the Johnson & Johnson vaccine. But the cross-reactivity isn't significant enough that contraindication to one means contraindication to other. That is not the case. What it means is if you were anaphylactic to polyethylene glycol, you have what is called a precaution to getting the Johnson & Johnson vaccine, which I'll come to in the next slide. Other components include sodium potassium salts and tromethamine, which is another component that is specifically for the Moderna vaccine. Important thing to note, allergies including anaphylaxis to other medications, other vaccines, or other food products are not contraindications to receiving these vaccines. Advising precautions and added waiting time is what's recommended, and I will come to that in the next slide as well. Being a part of a special population isn't a contraindication either. What I mean by special populations is immunocompromised, pregnant women, lactating mothers, those that may have autoimmune conditions, so on and so forth. Data on these populations is emerging. Whatever we know thus far is reassuring, but recommendations continue to be based on a risk-benefit analysis, given lack of hardcore conclusive evidence. So the CDC has done a great job. The link I have provided in the slide is talked about what's a contraindication, what is a precaution, and when can you proceed. If you see, even in the intermediate group where it's a precaution to vaccination, it talks about risk assessment, it talks about considering a referral to an allergist immunologist, and a 30-minute observation period instead of the regular 15 minutes, but nowhere does it say that precaution means contraindication. And this is something that we've really worked hard on in convincing patients to go ahead and get the vaccine, deeming it to be safe, unless they have an absolute contraindication, where we would mean to do this in a monitored setting or potentially with a product that does not share the mechanism or other constituents. Side effects. So important thing to understand, the first dose acts as the priming dose, the second dose acts as the booster dose in the 2-dose vaccines. So side effects were obviously more after dose 2 than dose 1, because at that point your immune system's revved up and ready to go. The side effects were lesser in older adults, but I do not want this to be a message saying reduced immunogenicity, meaning the response, the efficacy was the same, the side effects were lesser, so that should be seen as a good thing. Predominantly, it was injection site reactions, including pain, redness, and swelling. Systemic side effects were fatigue, myalgias, headache, and fever. This is what I'm talking about, the commonest symptoms. Localized lymph node swelling, especially in the arms and neck, and a delayed allergic reaction at the injection site, it almost looks like infection of the skin or cellulitis, was more prominent with the Moderna vaccine, but settled with the use of antihistaminics and other non-steroidal anti-inflammatory drugs. The expectation is you should not have these symptoms longer than 48 hours. If they do exist, then there's always the risk that you still have COVID, and we would urge you to get tested, especially if the symptoms match the disease. Severe adverse events were less than 0.5% in all these trials and matched across the placebo and vaccinated groups. Bell's palsy, which is a paralysis of the facial nerve leading to facial droop, was seen in the Pfizer vaccine group and Moderna vaccine group compared to none in the placebo group for both these products. However, the way CDC looks at this is what would be the incidence of these conditions were we not vaccinating in these months, then that's known as the background rate of this phenomenon. And if the background rate is same compared to what they saw in the trials, then the likelihood of a causal association with the vaccine is extremely low. Guillain-Barré syndrome, which is again a peripheral neuropathy of sorts, was seen in some individuals in the Johnson & Johnson trial, but again matched across both groups. There's been a lot of talk about blood clotting related disorders in the recipients of the AstraZeneca vaccine in Europe and Australia. The data is evolving on that front. A lot of countries went ahead and paused their vaccination schedules. However, the WHO and the European Union regulatory health bodies have come out and said that that should not be the case because the benefits outweigh the risks. No such phenomena was seen in the US trials. This is per the press release, and we are waiting for actual data to sort of draw our own conclusions. Again, this is important to understand what's a true allergic reaction, what may be what's known as a vasovagal reaction, and what may be a vaccine side effect. It's important to understand these differences both for the patients and providers so that we're not wrongly contraindicating vaccine or individuals who are scheduled for a second dose to receive an incomplete series and rendered non-immune because of this misconception as to what really happened and was it an allergic reaction or not. The CDC has done a great job in being transparent about this, and I really urge everyone to log on to that website. The links have been provided here to sort of go over this so that you're well informed and can make a right decision. Again, this is the CDC utilized an app-based platform to get real-world data about side effects. It's called vSafe, and whenever you get the vaccine, you'll be asked to register for it. They have looked at interim analysis every 3 months out of data that they got from vSafe and also from the Vaccine Adverse Event Reporting System, the VAERS. This is a slide that was adapted from the New Hampshire DHHS presentation last month, where if you look at the incidence of side effects, it's similar to patterns that was seen in the clinical trials. Obviously, the frequency of side effects was higher after the second dose, and clearly mentioned that side effects should not dissuade people from getting the second dose because, again, disease is worse than bearing a couple of days worth of symptoms. Anaphylaxis is something that got quite a bit of a bad rap early on. It's interesting to look at this comparison. Rates of anaphylaxis after receipt of COVID-19 vaccine, if you combine the Pfizer and Moderna data, and this is, again, I'm telling you when about a couple of months ago. This presentation was a month ago, but data was analyzed until end of January. And at that point, we had done about 8 to 10 million doses of each of these vaccines. And it was about 4.5 cases of anaphylaxis per million doses administered. And if you compare it to some other vaccines, it plays out pretty much the same. Interesting comparison, if you look at penicillin-related anaphylactic events, those are almost 1 in 5,000. So if that is something we can live with, this is definitely something that we can manage. Serious adverse events and deaths, essentially anything that happens after a vaccination is reported to CDC. It then digs into causes and tries to analyze if anything was related to the vaccine per se. But interestingly, if you look at the last line, the CDC estimates were that this was all within what would be expected out of long-term care facilities with respect to deaths from several other causes, and no consistent correlation with vaccines could be established, thereby rendering them safe. This is just another slide sort of going over what the percentage reactogenicity was as reported to vSafe. And mind you, not everyone who received the vaccine really logged into this and reported it on a regular basis. So this is obviously not the whole picture, but it's a good representation of what happened in the real world outside of trials for those who were concerned that the trials may have been hurried through. This again talks about the anaphylaxis, and when I said 4.5, that was sort of a combination of the two that we saw. So when we mention special populations, what does that mean? So pregnant women, lactating mothers, all societies have sort of gone and endorsed them to get the vaccine. These are not live virus vaccines, so the risks attributable to that is unlikely. We do know that COVID-19 can have severe adverse outcomes in pregnant women as well as on their unborn children. So weighing the risks against benefits, the American College of Obstetricians and Gynecologists, Maternal Fetal Medicine, IDSA, all of these societies have gone on to recommend this vaccine. And obviously, it's not mandatory that you have a conversation with your provider, but that is something that is encouraged. Immunocompromised hosts, again, the vaccines are endorsed because some immunity is better than no immunity. I can tell you from real world experience, we've seen a lot of cases where people were vaccinated. They do have history of being immunocompromised. They did get COVID after their second dose, after they would be deemed immune, but they were successfully discharged. And I can tell you for sure that had they not been vaccinated, the outcomes could have been way worse. Anyone with active or history of COVID-19, we are saying that complete your isolation period, after which you're eligible to get the vaccine. History of COVID-19 is not a contraindication. Early on, we were asking individuals to wait for 90 days. That is when there was a demand-supply mismatch. Even though that exists to some extent at this time, it's not as severe as before. And right now, even if you had COVID-19 in the last 90 days, once your isolation period is done, you're good to go and get the vaccine. Anyone with exposure to COVID-19 and on quarantine, we're saying do get the vaccine, but provided your quarantine period ends so that you're not risking the vaccine administrators to get COVID of their own. Anyone that was treated for COVID with convalescent plasma or monoclonal antibody therapy, we have asked those individuals to wait 90 days because we really don't know the half-life of these agents, and that may affect the immune response, hence the duration to wait before you get the vaccine. There is no data as yet on interchangeability of vaccines. It's only allowed in certain scenarios, such as healthcare workers, if they're getting employed and need to be vaccinated against Hep B and or flu, and did get the COVID-19 vaccine within the last 14 days, then those are certain exceptions. But at this time, the recommendation is to have a minimum 14-day period between you getting your COVID-19 vaccine and any other vaccine, so that you're not, preventing cross-reactivity. Again, there's no, so that was data around co-administration. Data on interchangeability, meaning you can't get Pfizer the first time and then Moderna the second. Again, the only situations where this is allowed is if you have extreme supply constraints and you're running out of that 6-week window, or if it happened by chance as an error, then CDC is saying no need to repeat the series. You should be good to go, provided you had 28 days between the 2 doses. So it's not recommended, but if it happens, it's not a big deal. So what's in the pipeline? Obviously, we're all looking forward to what the AstraZeneca Oxford vaccine is going to bring our way. Hopefully, by end of this month, we should see the data on that. Novavax vaccine depends on what the FDA decides to do. If they agree to take their Europe data and go ahead with it, we should have a result by May. If not, they're still actively working on their phase 3 trials, so it might be a while. All these companies in association with CDC and FDA have promised for long-term data analysis with existing products, especially for side effects through the established systems. Developmental and reproductive toxicity studies are ongoing. So Moderna and Johnson & Johnson are a tad bit ahead of Pfizer, but we have not seen any negative signals as of yet. These are all studies done in animal models. Studies in the special population, so immunocompromised hosts, pregnant women, lactating mothers. CDC's maintained an active registry of these individuals, and these studies continue, and we're looking forward to more and more data coming out. What's interesting is there are studies ongoing to assess reduction in asymptomatic illness and transmission amongst vaccinated individuals, and we are seeing really encouraging data coming out of Israel, which sort of leads the world with respect to community vaccination, as also internal CDC data, which is based out of healthcare worker vaccine administration that we've seen between December and February. All of these have shown a very positive signal in reducing any form of illness, including asymptomatic disease, and that is being used as a correlate or a surrogate for reduction in transmission as well. This is sort of being used as the stepping stone for updated CDC guidance that you all must have seen with respect to what can vaccinated individuals do and not do. And we're hoping that goes through several revisions as the months go by. As of now, Pfizer is the only one which has looked at how long does immunity last, and they've at least quoted that they had good antibody titers at 6 months out from second dose. But several other companies, I won't be surprised if come out with this sort of data in the next few months. Novavax vaccine, I'm not going to delve into much. It's a different platform. It's a protein subunit vaccine that's sort of traditional. That's how most vaccines were based early on. It's again 2 doses. US trials, they're still recruiting, but the UK trial data was promising, close to 90% efficacy, especially in the setting of mutant strains. But we'll just have to wait and watch how that plays out. So this is something important that I wanted to highlight because everyone's worried how a vaccine's going to do. There are mutant strains circulating. So there's a single mutation, E484K, which is the major culprit. It's a part of the Brazilian variant P1. It's a part of the South African B1351. It's a part of the California, the New York variants. But again, it is concerning, but there's promising emerging evidence, at least against the UK variant, that immunity post-vaccination is intact. The Johnson & Johnson vaccine was, as I mentioned before, a real-world trial against all variants, and we saw good promising results, at least with respect to preventing severe disease and hospitalization. At the end of the day, that's what we need. This is sort of being used as the basis for CDC guidance, where things are being carefully opened up, especially for those who are vaccinated. And one reality which we need to understand is COVID-19 is not going away. So our aim should be moving from a pandemic to getting this virus to a state where it's endemic. So it lives with us, we live with it, and essentially move around as we would do with influenza. We're close to it, but we're not there yet. And that is where this whole conflict between, are we opening up too soon? Why do we need to continue doing what we were doing? And vaccinations somewhere in between. So I would say it's still not time to take our eyes off the ball. We're in a better position, but these next few months are going to be crucial as we ramp up our vaccination efforts and see whether these strains gain stronghold enough that they create disruptions, or does this die down such that we have a comparatively much more normal summer. The slide here that I have put up, the graph, what I want to highlight here is essentially what I said before. So there are some vaccines here which are not available in the US, but essentially all of these, and look at the numbers they've trialed against, showed 100% protection from hospitalizations and death related to COVID-19. And if anything, this is the message that should be going out to the public, is when folks ask, why should I get the COVID-19 vaccine? I think there's no saying that this has disrupted our lives and really made us look at things in a very different fashion. We're not saying vaccine is your be-all, end-all solution. It doesn't replace stuff, but it adds to the mitigation measures till we gain better control. It definitely helps prevent severe disease, potential sequelae of the same. We're looking at a lot of patients with long COVID, meaning residual cardiorespiratory issues, CNS issues, hormonal imbalances, all related to this inflammatory phenomenon that comes post-COVID-19. And essentially vaccination may aid in preventing that. This is a safer way to help build protection and to march towards herd immunity. You don't want a virus ravaging through your population and getting people immune by way of natural infection, because the mortality rates might end up being high and your healthcare systems get burdened. So this is a good middle step to sort of get towards herd immunity, such that we can start dialing back on some of these things that we have introduced in the last year. Last but not the least, it helps disrupt the chain of transmission. So when you get vaccinated, understand that we're not at a point yet that everyone else has been vaccinated. We're slowly getting there, but we're not there yet. And what that happens is the more and more people who are eligible get vaccinated, potentially break these chains of transmission such that you even end up protecting the ones that are not vaccinated. And that in a true self is what is known as herd immunity. So the suggestion would be, get the vaccine when it is your turn. There is no reason to choose. The answer is, which one should you get? The answer is essentially the one that's available now. And I'm going to pass it on to Tricia to walk us through how that is possible.
Thank you, Dr. Khole. My name is Tricia Zahn. I'm the Director of Community Strategic Partnerships at the Center for Population Health here at Cheshire Medical Center. I'm also responsible for our Greater Monadnock Public Health Network, which is how the state of New Hampshire divvies up our local public health responses. I have experience working in the Centers for Disease Control and Prevention. I worked in infectious disease for vector-borne and zoonotic diseases, moved over to the Office of Preparedness and Response before moving back to New Hampshire, getting my master's degree in public health, and being at Cheshire Med in the Center for Population Health for about a decade now. Next slide. Just reminders, I have the privilege of speaking to many different groups. And so just reminders of being kind to yourself and being kind to others, of giving yourself grace and giving others grace. That simple doesn't mean easy, right? I think we've all thought about this in the past year, like, why does this have to be so difficult? Why does everything be so challenging? Why can't we, right? There's lots of questions, there's lots of unknowns, and it makes us really restless. The change is hard. We know that, we're humans, right? We don't like it. Change is hard, and change fatigue is real. So that weight that we feel when the policies keep changing, the guidance keeps changing, the phases keep changing, right? What do I get to wear at work? What can I wear at home, right? The PPE, everything is changing all the time. And so that this change fatigue is real, and it's far from over. And so how do we continue to prepare ourselves, aligning our expectations with reality? Next slide. So this is a visual of the public health networks in the state of New Hampshire. So it's split up into 13 different networks. The one that I'll be speaking about today is the Greater Monadnock Public Health Network. So that serves the 33 towns in southwestern New Hampshire. We're responsible for all of Cheshire County and then the 10 westernmost towns of Hillsborough County, so about 104,000 people. So Jane and myself are responsible for the public health emergency preparedness in this corner. If you are from a different part of New Hampshire, you can check out the nhphn.org and be able to look up your town and find the public health network and the contacts that are relevant to you. And Vermont has their health departments as well. Next slide. So like Dr. Khole mentioned, right, a lot of our presentations have been talking about the different phases and who's eligible for what phase. And currently in the state of New Hampshire, we've opened it up to all phases. And so everybody who is over the age of 16, anyone who has a vaccine that's approved for their emergency use authorization is now eligible to register. And so continuing to make sure that folks are going to vaccines.nh.gov to register for a vaccine appointment. You can also call 211 if you don't have internet access or aren't good with a computer, right? We know that the phases all add together. And so there are folks who are newly eligible, those age groups, as well as folks that may be joining New Hampshire who are now healthcare workers, maybe you're switching jobs, and so being able to be vaccinated. We've got a lot of folks that are over the age of 65 that had a lot of challenges registering with the systems, and so we know there's folks who registered at like the second week in January who have yet to be vaccinated as they watch other phases eclipse them, being able to navigate different systems at different rates. And so we're continuing to do a lot of community reach out, asking folks to reach out to their neighbors, to their friends, to figure out those that are interested in a vaccine who maybe have yet to have success. How do we make sure that those folks don't get lost in the shuffle, making sure that they're being vaccinated as well? So this is the visual for what we have in New Hampshire. And like Dr. Khole mentioned, Vermont will be opening up their phases as well. Next slide. So for our little corner of New Hampshire, some of our COVID-19 vaccine rollout details is we have our Greater Monadnock fixed site, which there are other fixed sites in New Hampshire. Ours is located in the Keene State College Athletic Complex. It's staffed by our amazing National Guard and Public Health Network volunteers. So we also include students, LNA and RN students. We average over 1,000 vaccines a day. We've had multiple days in these last few weeks where we do over 1,400 vaccines a day. We've done over 35 vaccines provided since December 2020. We opened the site the Saturday after Christmas, and we've been running it ever since. We have both Pfizer and Moderna on site every day. Vaccine recipients do not get to choose the vaccine product. In our region, we do have mobile clinics and closed points of dispensing that we're using our limited Johnson & Johnson allocation for. So these could be some of our homebound populations. These could be some residential facilities that are age restricted, so that we know that folks living in those areas are older, they don't have transportation, they might have disabilities, so that we can meet them where they're at, being able to have a one dose on site to limit any barriers to access to a vaccine. And then there's lots of vaccine provider agreements in the works. So that could be houses of corrections, hospitals, long-term care facilities, pharmacies. So lots of organizations that are now coming on board that they would be able to provide vaccines directly on site. We know there was a huge push, right, for the last couple of months in long-term care facilities for all their residents and their staff members. And now they're putting other processes in place so that they can have that continuing vaccine opportunity for those organizations. Next slide. This is just an example of what we're working with. We've experienced negative 6 degree weather, and that's not including any wind chill, right? That's not real feel, that's just what it is on a thermometer. But these look very different than what we have right now. And so we've got other photos. For better or worse, people are getting a little bit of mask tan. And so I feel like that's gonna be a badge of honor of sorts in 2021 of making sure we're using, right, sunscreen, but that can be challenging to do with 12-hour days, and making sure they're not slowly over the weeks starting to get a mask tan. Next slide. So day of vaccination tips. So for folks who have yet to be vaccinated, who have registered and you have an appointment coming up, our request is to please complete your pre-vaccine questionnaire in Vinny prior to your appointment if you can. So I know that if you've added an eligible family member, you might not be able to do that. If you registered on 211, right, there's no way for you to do that pre-vaccine questionnaire. But we're just requesting the folks that do have the ability to please log into Vinny, do your pre-vaccine questionnaire on the day of your appointment. Making sure that folks are bringing their driver's license or a photo ID, proof of New Hampshire residence if needed. So if someone lives in Vermont, but they work at a hospital in New Hampshire, right, you're bringing that badge. Or if you live in Massachusetts, but you're a teacher in New Hampshire, then you're bringing that badge. Otherwise, with all the phases opened up, it's New Hampshire based on ages. And so that's a perfect opportunity for a driver's license. Making sure that you're bringing your confirmation QR code printed or quickly accessible on your phone. It doesn't work every time. Not all sites use it the same, right? So you might have gone to a site and been like, well, I didn't use it last time, so I didn't bring it this time. But the IT is changing every single day. The systems are getting updates on a regular basis. And so opportunities present themselves to make things move a little quicker. And so there's lots of variables any given day that can lead to a longer line, can lead to a longer wait. And so one of those can be making sure we can find all our appointments really quickly. And a QR code can be one of the ways that we can do that. Making sure that folks come dressed for a vaccine. You would be very surprised how many people show up and are not prepared to show us their shoulder, right? So we're looking for this very high part of your shoulder. And so folks, even if they're waiting for a long time, by the time we get to their car, now they're figuring out how to get us access to their shoulder, right? So just being prepared when you show up on site to make it as easy and quick as possible, and just be prepared for a wait. So I like to under promise and over deliver. Right? So let's all just plan for a wait. Let's gas up our vehicles, bring a snack, bring water, bring a book, hit the bathroom before you leave, right? This is a mass vaccination campaign during a pandemic. We're giving free vaccines to anyone who's interested to ideally, right, end this pandemic as soon as we can. And so just prepare for a wait. It's not perfect. We're working on a lot of variables. And so just kind of setting that expectations, right? We're all doing our best, trying to streamline it, but just hopefully being pleasantly surprised. And then just bringing kindness and a positive attitude. So there's so many folks who have been pulled from their families. There's people who live in hotel rooms that are now serving our state in a different way, right? Their lives have been upended. We've got a lot of volunteers that are volunteering their time. They work a lot, they're retired, right? And they're coming to these sites to give up their personal time to vaccinate our communities and managing the weather elements and all these things that come along with it. So just knowing that a lot of these folks are answering the same questions, right? Every single day, thousands of them at a time. We got some people who are really kind, some people who are not so kind. And so just creating that space is really important as we all navigate these challenging times. Next slide. Some of the frequently asked questions, we've got some hyperlinks that you folks will have access to, the Cheshire Med website, vaccines.nh.gov. There's lots of FAQs that we encourage you to check out. We do have our vaccine equity allocation, and so being able to register on there to make sure that folks all have access to COVID-19 vaccine for those who are interested. Knowing now that we have our VINI system, the Vaccine and Immunization Network interface. Second appointments are booked right on site through the VINI system, so making sure that we can see those calendar of availability so that folks know when they'll be able to come back. And then we have our 16 and 17-year-olds, right? They're now eligible to receive the Pfizer vaccine. Don't worry, whatever site they're booked at would have the Pfizer to provide them, and a parent or guardian must be present right now at the time of vaccination. They're working on a availability for consent in a remote way, but right now we're having parents or guardians be present at the time of vaccination, which are some of our more frequently asked questions these days. Next slide. I think that's it. Yeah. So Dr. Khole and I are here more than happy to answer any questions, and we appreciate the opportunity to speak with you today.
Hi, this is Angelica. I am moderating the questions this afternoon. So if you have any questions, please feel free to use that Q&A function. We have a couple questions in right now. Specifically regarding, and you touched on it a little bit, the side effects. So could you just talk about, or the risks, excuse me. So could you talk a little bit more about the risks of getting the vaccine if you are pregnant or are planning on becoming pregnant around the same time as getting the vaccine?
Sure. So there was some concerns early on. There was some chat in the media about potential issues with fertility that may be arising out of these vaccines, but we have really not seen any such signals especially after the millions of doses that have already been administered. As I mentioned, the CDC is tracking especially the pregnant healthcare workers that were a part of these first trials. They're being monitored as a part of the separate registry. And we've really not seen any major side effects. There were individuals who got pregnant after they received the vaccine, so concerns about fertility have sort of been squashed at this point. Obviously, that will continue to be monitored because, again, as Tricia mentioned, it's a pandemic, lots is changing and things are changing every day. But I think if you try and understand the science behind it, these are not live virus vaccines, right? So it should not, pregnancy is considered a time during which you may have transient immunosuppression. And you're worried about live virus vaccines essentially manifesting the disease in itself. But given that these are not live virus vaccines, that risk is essentially eliminated. What we do know is because of that transient immunosuppression, the outcomes from COVID-19 in pregnant women and including effects on the unborn child are more significant than compared to someone who's not. So I think when you balance the risks against benefits, that is where vaccination sort of gets the upper hand, and hence all the societies have gone on to endorse this.
Thank you. We have a question. Can you talk about if you've had COVID-19 already, why would you want or need to get the vaccine?
So that's a great question. So as of now, from what the CDC is basing these recommendations off of, is we do know that the chances of reinfection, at least for the first 90 days after you get the disease, is low. But we really don't know how long does that immunity last. There have been claims where we may say, okay, people had detectable antibodies for almost 6 to 8 months out after their infection. However, we've really not done large-scale trials to analyze that, saying, okay, what after that? And is that 6 to 8 months consistent across all age groups, consistent across comorbidities, racial ethnic disparities? We really don't know. And when you look at a disease and vaccine-induced immunity, there's always the likelihood that vaccine-induced immunity is going to last longer. So the way we are approaching it right now is, even if you had COVID-19 before, getting an additional vaccination is going to act as a booster, which may promote immunity. There's really no harm from getting it. So if anything, it may, only add to the benefit rather than nothing. So why not? And that is predominantly the reason why we're pushing anyone and everyone to get vaccinated at this point, irrespective of history of the disease.
Thank you. So we have another question about the contents of the vaccine. Someone is concerned that there is mercury in the vaccine. Is that true?
None of the vaccine products, Pfizer, Moderna, or Johnson & Johnson, have mercury. They don't even have thimerosal, which is the other concern that is often asked about. So anyone who's concerned about that should be rest assured that it's not in there.
Thank you. And then someone asks, if you refuse the vaccine at the time of your appointment for any reason, will you have another chance to register and receive it if you choose to in the future?
So if you arrived at one of the state fixed sites for your appointment and for whatever reason decided that today was not your day, you would be able to cancel that appointment, log back into Vinny, and choose another appointment day and time.
Thank you. And then another question is, what is the current percentage of the population that needs to be vaccinated in order to squash this pandemic?
So that's a great question. That's a question I come to every morning. But I think the way to look at that would rather be, what's the percentage of the population that you need immune? Essentially, what's that magic number for herd immunity where we may consider this pandemic to be sort of dwindling down? Because the way I like to approach that question in this format is because you could develop immunity because of natural infection, or you could develop immunity because of vaccination, or both. And I think the eventual goal of herd immunity is not going to be attainable just by vaccination, because that number is fluctuated between 70 to 90%, depending upon what strains are circulating, what's the current course of the pandemic. And we all know, from a healthcare worker perspective, when we've looked at this data, acceptability rates of the vaccine are anywhere between 60 to 80%. So the way we like to analyze that number is, okay, how many individuals who've been infected and recovered are potentially immune? We do know that for every positive case that we diagnosed, we potentially missed 3 or 4 more cases because folks never turned up for testing or were asymptomatic and never realized they were exposed. So that number, coupled with the percentage vaccinated, together is going to amount to herd immunity, and we're quite a few ways away from that at this point.
Thank you. I have another question. What happens if you get the second vaccine too soon or too late?
So I think the question is what's too soon and what is too late. So, as I mentioned, at least in the 2-dose vaccines, the first dose is the priming dose, the second dose is the booster dose. So if you've not allowed the body enough time to get primed and you get the second shot too soon, likely that your efficacy might be lower. Also, if you wait too long, now again, if you look at some of the data that came out of UK, which did a real world experiment by literally phasing their AstraZeneca vaccines 12 weeks out, and they still saw, close to 80% efficacy in individuals who'd gotten a single dose in those intervening months. And that got boosted to 90 plus when they got it at the 8 to 12 weeks interval. So it may work. However, I think what we need to stick by is how the trials were done and what the data depicts, right? So the trials were studied in a way where we looked at what happens if you get the second dose at the 4 weeks mark. We do know from extension of those studies that up to 6 weeks out, you're still okay, such that you're within that window of developing immunity, that you should be able to mount a significant enough response and the vaccine to be efficacious. Anything after that is a matter of guess at this point, because I think unless you have data to prove it, it's really hard to make those recommendations.
Great, thanks. Another question, is there any correlation between the vaccine and blood clots or aneurysms?
So that's been a cause for discussion more related to the AstraZeneca vaccine. Essentially, and what we're going by is what's being talked about out of Europe, because as I mentioned, at least the press release with respect to the US trials didn't show those side effects. We do know that vaccines generate a hyper sort of inflammatory response, and whether that makes you a little more susceptible to blood clots is a possibility. However, as I mentioned, you have to look at background rates of this phenomenon in a population which, if it wasn't to be vaccinated, would you still have the same incidence of blood clots? Would you still have the same incidence of aneurysms? And if the answer is yes, then there's really no way to prove a causal association. There is talk about the AstraZeneca vaccine related to what's known as a vaccine-induced thrombocytopenic, meaning low platelets promoting blood clots. That's been talked about in Australia and in Europe. But again, the incidence was not significant enough to essentially pause vaccination schedules. Some countries went on and did it, but that may not be recommended in current times.
Thank you. So Tom says, thank you for the tips for receiving the vaccine. Any tips for the recovery after the shot? Exercise, icing, ibuprofen, that kind of thing?
Yeah, so we are saying that don't try not to take any medications before the shot. After the shot, taking Tylenol or ibuprofen or any other non-steroidal anti-inflammatory drugs is fine. There is a chance that you will have more side effects after the second dose, so people should be aware of that. From personal experience, the arm gets quite sore, and frankly speaking, exercising it, I don't believe I would have been able to do that. Icing, if it works for you, sure, but there's really no contraindication to doing all these things which are conservative and otherwise effective.
Okay, someone asks that they've heard that babies are being born with antibodies after the mother was vaccinated. How does that happen?
So essentially, the antibodies are of the IgG type, which is a type of immunoglobulin that does cross the placental barrier. So there is a chance that if the mother either had COVID during being pregnant or was vaccinated, that she may transfer some immunity known as passive immunity. There's also a theory that whether that could be transmitted through breast milk, and that's how it's detectable in the babies. But that's sort of the background that's being used to say that, to promote vaccination in that particular group.
Why does it seem that the older population is not getting sick with their second dose, but the younger generations are?
That's a good question. And there's really, it's been talked about, it's been debated. Early on, folks were worried, is that because of a waning immune system? And does that mean that they didn't develop as robust a response? But that wasn't the case, because when we look at the efficacy in preventing illness, they actually broke it down into age-related cohorts, and the efficacy was it played out to be the same across all age groups. So really no reason why they should not develop as adverse a reaction after the second dose, but at the end of the day, the efficacy is not affected. I think that's the key portion.
Yeah. Someone asks, will we ever have a choice on what type of vaccine we'll be able to receive?
So we don't have a plan for that right now at our state fixed site. So right now we're, I think Dr. Khole will agree with me, right? The best vaccine is an available vaccine. And so we don't have the opportunity to choose right now. We don't know what the future looks like. It could be something like a flu vaccine where you can decide on the presentation of a flu vaccine and choose your pharmacy, your doctor's office, right? And so the COVID-19 vaccines could look like that in the future, but currently for our pandemic rollout, it's the site specific. So if somebody was invited to go to one of the larger sites like Loudoun and they knew they were going to be doing Johnson & Johnson, right? You could decide if you were going to say yes to that appointment or not, or choosing to go to a different site. You know that they have Pfizer, Moderna, so you're essentially choosing to have an appointment there. But right now that's a limited opportunity.
If someone has an allergic reaction to a tetanus shot, would they be more likely to have a reaction to this vaccine?
So again, hard to predict, but allergic reaction, including anaphylaxis to any other vaccine, should not be a contraindication to any of these three COVID-19 vaccine products. As I mentioned, it may serve as a precaution, which means if you're really concerned, you can choose to discuss it with your provider, allergist, immunologist, and that you will be monitored for 30 minutes after your dose instead of the routine 15.
Does there seem to be a lesser reaction in the second dose of either of the vaccines? So comparatively, Pfizer to Moderna?
Not really. To be honest, it was quite surprising that different companies, same technology, but different product, but the trials literally played out as if they were mirrored. So the efficacy, the side effects, the incidence of the side effects post first dose, post second dose, and the efficacy across age groups was almost identical. So no real difference between, and same for Johnson & Johnson. I mean, the side effects were the same after first dose as were with Pfizer and Moderna.
And then why is it that 16, 17-year-olds can only get the Pfizer vaccine at this point?
So that is how the emergency use authorization was granted to that product. So when Pfizer did the trials, they did it for 16 and older. Moderna and Johnson & Johnson did their trials for 18 and older, as a result of which the 16-17 bracket, Pfizer is the only vaccine that's approved right now.
So we're coming up on our time. We have 3 more questions that I think we can get to. If people have more questions, how can they get those questions answered? What's the best way?
I think if I don't know if Karen wants to sort of compile those questions and send it our way, and we'll be happy to answer them over email if that works.
That sounds great. Yes, just email your questions. We'll provide our email address to Mariah, who I believe is on the presentation in the audience, and she can get me those questions, and I'll get them to Dr. Khole and to Tricia, and then we'll get the answers back to you all.
So here's the last 3 questions. The first one is, Do you know ahead of time which vaccine you were getting? I live in Vermont and it did not tell me on the website, but in New Hampshire it tells you. Am I missing it anywhere on the Vermont website? Would you know that answer?
Not that I know of. So I know that the VINI, the new New Hampshire system, shows you what products are available at that site. I do not believe it guarantees which one you will receive for your appointment. And the same thing for like Walgreens and other access points. I think it tells you what is available, but I don't know that it's a guarantee on what you will receive when you arrive.
Tom asks, the flu has been subdued for this year. Could it make a real comeback next year? And if so, should we make sure to get our flu shot next year?
I think that is a great question. I will start saying at the outset that it is important to get your flu shot every year. So we should not let flu dynamics decide which year to get it and which year to not. However, Thomas raises an interesting point, which is being talked about, that this year literally we've seen almost no flu activity, nationally. But what that means is every year, because we are repeatedly exposed to flu, folks carry over some immunity from the last time into the next season, such that you're partially protected, and then you get the new flu vaccine, which may be tailored to certain strains and sort of boosts your immunity. But what's happened this year is even, for those individuals who may not have chosen to be vaccinated, will potentially have no residual immunity next season, such that if flu was to circulate, it's like they're new hosts with no memory of this, and the outcomes might be more severe. So I think you're right. Next year, more than ever, consistently getting your flu vaccine when offered, when opened up, is going to be key.
All right, thank you so much. This is our last question of the afternoon. And that's a great question. Will another shot or dose be needed over time? As in, will we need to get a booster or some kind of like a flu shot every year?
There is a good chance that will be the case. Now, whether that booster shot is needed because immunity wanes, or whether the booster shot will be needed because you have circulating strains that you want to modulate your product to, or both. The likelihood that you will need a booster shot is pretty high. And it may be something similar to what we do with the flu vaccine. The question is, what's the indication? And I guess time will tell.
Great, thank you so much both for being here and for answering all these questions and for this great overview of the COVID-19 vaccines. Is there anything that you would like to add in closing?
Essentially, get your shot when you're offered one.
Thank you for the opportunity, and I'd echo that we've seen that hand hygiene can work, that some physical distancing can work. So just continue to take care of our spaces and take care of each other. So thank you for the opportunity.
Thanks for having us.
Thank you both so much, and thank the Mascoma team for arranging this for us. And again, please send any questions to Mariah, and she will get them to us for responses by Dr. Khole and by Tricia. And we're so pleased to be able to do this for you. So thanks, everyone. Have a great afternoon.